Good afternoon, everyone, and you're really welcome to QPS TalkTime. This is our 16th exciting session of this series. And I'm Maureen Flynn, and I'm going to be your host today. You'll also see we connect out using social media with everybody involved in quality and safety across the country. I find it very hard to say the word X, but Twitter now is X. So you'll see at QPS TalkTime is our handle. This webinar and most of our webinars are recorded and made available back for anybody to listen to 365 any time of the day through our YouTube channel. And you'll see the address of our YouTube channel there. And we have a growing followership on LinkedIn. We'd love you to join our LinkedIn channel. For those of you who may be not that keen on Twitter, LinkedIn is another really good space to connect together. And I should have said at the very start, this session is being co-facilitated by myself, Maureen Flynn, and my colleague, Dervla Hogan. So today we're talking about quality improvement in stroke care. So we're going to learn about the importance of swallow screening. We're also going to gain an insight into quality improvement in practice in Sligo University Hospital. And most importantly for you, our audience, we're going to share takeaway tips and tricks in implementing quality improvement that you can take away with you from our session. So without further ado, it's my pleasure to introduce our speakers and panel today. So Joan McCormack is joining us from NOCA. Joan is the Cardiovascular Program Audit Manager. Fiona Connaughton is Interim Nurse Lead for the National Programme for Stroke Care. Julie is the Joint Health and Social Care Professionals Lead for the National Programme for Stroke Care. And Carney is a Clinical Nurse Specialist in Stroke Care in Sligo University Hospital. So I've done loads of talking now. Without further ado, I'm going to hand over to Joan. Joan, thank you for joining us today.
Thank you very much. Thank you for inviting me. So yes, my name is Joan McCormack and I'm the Cardiovascular Program Audit Manager in NOCA. And ultimately what that means is I manage the Irish National Audit of Stroke and the Irish Heart Attack Audit. So NOCA is the National Office of Clinical Audit, and NOCA manages a suite of clinical audits. Each audit focuses on a unique area of healthcare, such as hip fracture, major trauma, hospital mortality, ICU, and at this point we've got about 12 clinical audits, and most importantly for this talk, stroke. So NOCA audits inform the general public about how specific areas of their healthcare system are performing against recognised standards of care, and they also support healthcare staff, management and policymakers to better plan and improve patient care. And you can see on the slide here a series of national reports and patient summary reports that NOCA has published in recent years, and they're all available on the NOCA website. So in 2023, NOCA looked back over its 10 years of implementation since 2012, looking at the impact of national clinical audit. I mean, the aim of NOCA is to improve patient care through national clinical audit, and this report shows the impact of national clinical audit at a national, local, policy and public perspective. And what we found was that, you know, the data that is collected is really helping to drive policy, such as things like maybe the trauma network and the National Stroke Strategy. NOCA has a keen QI focus, and every year they have a QI Champion Award, and the next conference for NOCA will be February 2024, and there will be a call out shortly in the next couple of weeks looking for more audit champions. So just in relation to the stroke audit, the Irish National Audit of Stroke, the stroke audit began really back in 2011, 2012. And at that time, the National Stroke Programme was established, and the stroke model of care was published. And in order to monitor the implementation of the model of care, they developed the National Stroke Register, which really was the first iteration of the Irish National Audit of Stroke. And over the years, different reports were published based on the data from the National Stroke Register. In 2015, this is a timeline really of the stroke program, and I guess the stroke register as well. In 2015, there was another national stroke audit completed, which did show quite significant improvement in the delivery of stroke services since the first one, which was done in 2008. From then on, from 2016 on, we produced a national report annually of the National Stroke Register, and we added to the data set added things like the thrombectomy data set, and implemented the HSCP data set as well in 2018. In 2019, the National Stroke Register transferred governance from the National Stroke Programme to NOCA, and since then it's known as the Irish National Audit of Stroke, and we've produced annual reports and quarterly reports since. So this is just a map of all the participating hospitals. In Ireland at the moment, there's 24 hospitals provide acute stroke care. So what that means is if somebody calls an ambulance, they will be brought to one of 24 hospitals that provide acute stroke care. And all of those hospitals participate in INAS. Each hospital has a clinical lead and an audit coordinator. And all of the audit coordinators are experienced stroke nurses, clinical nurse specialists, advanced nurse practitioners in stroke. And we're eternally grateful to them, because only for them we really wouldn't have the audit at all. So how are we using the data to improve stroke care? Well, the first thing is, I guess, we produce an annual report every year, and that shows national results, and it also benchmarks each of the hospitals against the national results. And of note, last year's report was a trend report of 9 years of stroke data. So there's a huge amount of information available in that report, but also in the appendices as well. Again, all of these are available on the INAS page on the NOCA website. We also developed an INAS dashboard, and this dashboard is available quarterly to all hospitals who are participating in INAS. And 7 key quality indicators were developed from the National Stroke Programme and the Governance Committee for INAS to really identify the key areas where we can improve and drive quality patient care. So the first thing we look at is how many patients are admitted into a stroke unit. The target is 90%. The second one is, if you go to a stroke unit, how long do you spend in a stroke unit? And again, the target is 90%. Thrombolysis, how many patients are getting thrombolysis? How quickly are patients having their brain scan once they come into hospital? How quickly are they getting thrombolysis if they're suitable? And key performance indicators, looking at really, how multidisciplinary we are in stroke, is looking at the swallow screening. So we look at how many patients had a swallow screen and how quickly have they had a swallow screen. Each hospital gets this dashboard quarterly, and it's benchmarked against the national result. NOCA is in the process of providing each hospital, each audit coordinator and clinical lead with licenses so that they can access this dashboard live themselves. So have we seen any changes? And I guess I can break this into 3 parts. First of all, in some ways we haven't seen changes, and there's information in that. So for example, KQI1 admission to a stroke unit, really we're ticking along at about 70% patients over the last 6 or 7 years going into a stroke unit. And similarly with thrombolysis, you know, it's in or around 10 or 11% over the last number of years. And so what can we do with that? And we really use that information. Things need to improve. And that information really drives things like the organisational report that was produced, and also the National Stroke Strategy, which can use that data to advocate for more resources in the system. Do QI projects impact nationally? And I think really quickly, yes, is the answer to that. Anyone in stroke world is familiar with the Georgia Decision National QI Collaborative, which was led out by the Thrombectomy Service of Beaumont Hospital. And they looked at every process in the emergency care phase of stroke. And you can see here quite clearly that once the QI collaborative began, the timings for things like, you know, George imaging, George seeing a doctor, time for thrombolysis, all improved. And we can see that year on year going into the most recent year. And what about swallow screening? So swallow screening is one that where in 2016, once we put it into the data set, quite quickly you could see that people were getting the swallow screen, and then it sort of flatlined at about 60%, and we were really getting no further than that. And then one of our recommendations was that we really should improve the swallow screen target in stroke. And so that's what the stroke program are doing, and the focus of this whole webinar. And they are looking at 4 hospitals to start with, and I just quickly looked at each of those 4 hospitals, their own data, and they know I'm sharing this screen. And it's lovely to see that we've got hospitals at different levels of implementation, I would say. Some that were actually doing quite well. So Sligo University Hospital, you know, on average they were over the national mean, and then you have other hospitals that were up and down over the years, I suppose, due to many reasons. And I guess INAS is really looking forward to seeing how the QI will change this, and to see will these hospitals and all the other hospitals in the stroke world improve following on from the collaborative. And finally, just to say that the next stroke report is going to be published on the 15th of December, and we will have a launch event on the 15th, and you can register, use the code here, and you'll find that on the NOCA website as well. So that's it for me. I'm going to hand over to Julie Keane now. Thank you very much.
So thank you, Joan. My name is Julie Keane, and I am the Joint HSCP Lead with the National Clinical Programme for Stroke. So I'm delighted to tell you a little bit about our Quality Improvement Project. This is one that myself and Fiona Connaughton, the Nurse Lead for the Clinical Programme for Stroke, have been involved in the last year. So I'm going to give you a little bit of an update in terms of the background and where we're at now. So firstly, just to look at the background. So the first question I would ask myself is, does swallow screening matter in acute stroke care? And definitely it does. And I'm going to tell you a little bit about why. So firstly, dysphagia is a really common condition in acute stroke. There's been lots of research done in this area showing as well that it's associated with negative healthcare outcomes. And positively, we have recently found that dysphagia screening has been found to have a protective health benefit. So firstly, looking at the prevalence. So a recent meta-analysis was completed, and this found that the prevalence of dysphagia in acute stroke care is approximately 42%. However, the studies were very different. And the reason that the studies were different is dependent on when dysphagia was assessed. So as you can imagine, if it was assessed on day 1 or day 2 post-stroke, you might have a very high prevalence of dysphagia. Whereas if it was assessed at week 3 or week 4, you might have a lower prevalence. Other reasons that the prevalence varied is dependent on how dysphagia was assessed. So in some studies, you might just have a chart audit and a review of the chart and dysphagia was noted, or dysphagia could have been assessed based on the result of a screening assessment, a clinical bedside assessment from a speech and language therapist, or indeed from an instrumental assessment. And you can see here on the next point, when instrumental diagnostics are used, so for example, that would be your videofluoroscopy or your FEES, your fiber optic evaluation of swallowing. prevalence went up to about 75%. So really what we found is that dysphagia is very common in acute stroke. Luckily, we do know that dysphagia after stroke can improve for most of our patients, and it can resolve in that acute phase either spontaneously or with rehabilitation. But for some patients, it can persist into the chronic phase. This could be for patients who have a severe stroke, but a brainstem stroke, or perhaps have a history of multiple strokes in their past. And this means that stroke is one of the most common causes of dysphagia. So just to go through maybe some of the literature around the outcomes that have been associated with dysphagia. So we're all familiar with hearing how it's associated with pneumonia. So I've just quoted 2 studies here at the start, and they say that people with dysphagia are 3 times, and those who aspirate 11 times more likely to develop pneumonia. We also know that it's associated with malnutrition, and this can impact on a stroke patient's ability to engage with rehab, which can in fact compromise the effectiveness of rehab for that patient. It's also associated with reduced quality of life for patients, and for those of us who are working on wards every day, we're very familiar with seeing that in our patients. It's also associated with increased health costs. So if you think of your patient with dysphagia, they may get an aspiration pneumonia, they may need antibiotics, their length of stay may be increased in the hospital, and they may need alternative feeding as well. Also, research has found that there are increased odds in hospital-acquired mortality, and it's been found to be dysphagia, the second most important factor after stroke severity in terms of death after stroke. A recent study from 2023 looked at stroke-associated pneumonia in people with a severe stroke, and it's been linked with higher mortality in that population. This study also went on to suggest that if we can avoid pneumonia in this cohort of patients, we can potentially reduce mortality by 43%. So I suppose one of the questions is, what can we do to try and reduce those negative impacts associated with dysphagia in our acute stroke population? So that really brings us on to dysphagia screening and the role that it plays. So it has been shown to have a protective health benefit, and particularly in terms of reducing some of the outcomes such as pneumonia, mortality, dependency, and length of stay. So going back to that question I posed initially, does dysphagia screening matter in acute stroke? Yes, it does matter. So the next question probably worth asking in terms of dysphagia screening in acute stroke is, when should it be completed? So we're lucky working in stroke that there are lots of guidance documents for us internationally in terms of guiding our best practice. This slide just shows some of those guidance documents. And as you can see, there's really 2 trains of thought at the moment in terms of when dysphagia screening should be completed for our stroke patients. The first is within 4 hours of arrival or admission to the hospital. And you can see this in the BIAS guidelines and also in the guidelines from Australia and New Zealand in 2022. The other train of thought is that screening should be completed really as soon as possible or as fast as possible after admission or arrival. And you can see this in the ESO guidelines document there from 2021. And also in the Canadian Stroke Best Practice Guidelines from 2022. So just going back to that systematic review that I mentioned on a previous slide, really what the overwhelming evidence is telling us about swallow screening in stroke is that there is a very large positive impact of early versus late screening. And we can see that in the odds ratio for pneumonia. So definitely those patients that are in the early group in terms of screening, when they pull together all the evidence that's been done so far, shows that there is a lower incidence of pneumonia in that population compared to the late screening. A point of note, and it's something which the last point here on the slide is that in that systematic review, early was defined quite differently across different studies in terms of dysphagia screening and stroke. So 3 articles, for example, defined early as 24 hours. 1 article defined it as less than 4 hours. And then 1 article as less than 79 minutes. So you can see that variance there. And I think that explains in some way the variance that's in the international guidelines at the moment. So in answer to the question, when should swallow screening be completed for acute stroke patients? Really what we're seeing is the overwhelming evidence is the earlier the better. So following on from what Joan was mentioning there with the INAS audit, there are two targets or two key quality indicators in relation to swallow screening that we're being benchmarked against at the moment. So the first is the overall percentage of cases who have a swallow screen completed. You can see from the graph on the right hand of your screen that really we haven't made much gains or inroads into that over the last number of years. So you can see the levels from 2018 went from 68%, 67 and back to 68. So we're kind of stagnating at that 68%. So clearly there's more that we can do. The second KQI in relation to swallow screening is that patients should have their swallow screened within 4 hours of hospital admission. Again, you can see on the graph on the right-hand side of your screen that numbers haven't really changed again with regards to this target over the last number of years. So it seems to be hovering at around 43%. So really what this is telling us again is that definitely we could do much better in Ireland in relation to swallow screening and stroke care. So really there's an onus on us to try and make things better. And the methodology that we are using at the moment to make things better is quality improvement. So what is quality improvement? Quality improvement is the combined and unceasing efforts of everyone involved in healthcare. So that would be your healthcare professionals, patients, families, commissioners, researchers, in making the changes that will lead to better patient outcomes, better experience of care for our patients, and continued development and supporting of staff in delivering quality care. So this slide here just is a graphic to show you what we've been working on in the last year in this quality improvement project. So our overall goal is to improve the quality of swallow screening in acute stroke in Ireland. We've had two strands to this piece of work. The first was the establishment of an expert advisory group, which has been seeking to do two things. Firstly, to seek consensus on that timestamp for swallow screening that we will adopt in Ireland. And this relates to my earlier slide where I explained the variance that currently exists in the evidence and the literature. The second thing we've been looking at is the possibility of using one swallow screening tool nationally. This has come from a survey that we did at the end of last year. And we found out that there are over 9 swallow screening tools being used at the moment in stroke in Ireland. And people cited barriers to successful swallow screening in their sites. And the barriers that were cited included things like lack of resources on the ground to implement swallow screening training and high turnover in nursing staff. So we felt if we could get consensus on one tool to use, we could develop an online module on HSE land to just reduce the implications for resources on the ground to deliver that training. The second part of our project this year has been going to pilot sites. So we have 4 pilot sites where we've been working on a quality improvement project. And this has been phase 1 of our quality improvement project. And just as I've highlighted there at the end of your screen, the goal so far has been to improve the overall rates of swallow screening in these pilot sites. So for this phase 1, what is our target? Our target is to achieve 100% swallow screening rates for acute stroke patients. We're going to be calculating this at the end of Q1 in 2024. We had some deliberations over whether we would go for 100%. We were querying whether we should go for 90%, is it more realistic, 85%? So there was a lot of back and forth between the team when we eventually selected this target, but we aimed high and we decided to aim for 100%. So where has this quality improvement project been going on? As I said, we have 4 pilot sites. So Sligo University Hospital, the Regional Hospital in Mullingar, St. Luke's General Hospital in Carlow, Kilkenny, and the Mater Hospital in Dublin. The change methodology that we've chosen for this QI project has included things like process mapping and PDSA cycles, or Plan, Do, Study, Act cycles. So this is the end of my presentation, and I think it's a good point for me to pass you over to Margaret Carney, who is a clinical nurse specialist in stroke in Sligo University Hospital, and she's going to tell you about Sligo's experience of engaging in this quality improvement project. Thank you.
Thank you very much, Julie. Hi, everyone. My name is Margaret Carney, and I'm currently working as the Stroke Clinical Nurse Specialist in Sligo University Hospital. Today, I'm going to use the storyboard to tell you why and how we implemented our Swallow QI project in Sligo. So our project aim was to achieve 100% swallow screening rates for our acute stroke patients in Sligo. Our core team consisted of the people you can see on the slide there, Dr. Hickey, who is our consultant lead for stroke, Una Moffat, who's the registered advanced nurse practitioner, myself, my speech and language colleagues, Cleena and Dorothy, and the speech and language manager, Sinead. So that was our core team. However, we needed lots of people involved. So we had a broad range of stakeholders. These included senior management, so our director of nursing, our general manager, right down to our staff nurses on the acute stroke unit. The team worked well on site as there was agreement from all parties about the benefits of QI. We all shared similar thoughts on what we wanted to achieve. So our background and context, as you'll have heard previously from Julie, there is a high instance of dysphagia in acute stroke. People with dysphagia are more likely to develop pneumonia. Lots of research is available and it will show you the benefits of swallow screening, and these benefits include reduced rates of pneumonia, lower rates of mortality, and reduced lengths of stay. The main reason for us completing our QI project was to benefit our patients. We wanted to increase our standard of care that we deliver in Sligo University Hospital. Some of the other reasons included recommendations from the National Stroke Strategy. They wanted a QI project to be undertaken, and we also wanted to look at our local results. So you can see here in 2021, we had done quite well at 68%. We were kind of hanging around the national average. In 2022, we managed to increase it to 86%. So really, we had done quite well. We weren't sure, was there more room for improvement, but as a team and with Julie and Fiona's support in the National Clinical Stroke Programme, we wanted to see if we could achieve 100%. So we were good, but we weren't good enough. Our key project measures, our outcome measures included 100% swallow screen rate for the duration of our project, and we also wanted to look at our compliance with documentation. Our process measures included a baseline audit of 5 stroke patients. We looked at individual hospital figures and how many staff we had trained, and we also completed a self-assessment questionnaire with the staff on the ground. Our balancing measures included looking at the workload for staff. Was there going to be learning opportunities? Although our focus was on swallow screening, we also were curious to see if our 4-hourly target would increase. And we also wanted to look at the positive and negative impact of referrals to speech and language. Was this going to increase their workload? So we used the PDSA cycle. It's a very useful resource when implementing QI. It involves a continuous loop of plan, do, study, and act. It's simple and effective in healthcare when you want to problem solve and manage some change. So how did Sligo plan their improvement? So we met up with Julie and Fiona initially, and we completed some process mapping. So we took out our blank pages and our sticky notes, and we spoke freely, I suppose. We looked at what barriers and facilitators we had, and we also looked at our pathway for our stroke patients from the emergency department to the acute unit. So we thrashed out all our ideas. We discussed what our assumptions were around swallow screening. So this involved looking at our severe strokes, who potentially could be end of life. Often they were not formally screened, or they were screened and it wasn't documented clearly. Was there room for improvement here? We also looked at the assumption that the milder strokes, these are patients that are mobile at ward level. They were well, so they weren't prioritized for a screen, but they potentially could be at risk of aspiration and possible negative health consequences. So what could we do to address this? So we proceeded with our PDSA cycle 1. So as you can see here, we looked at each stage individually. We planned, so we met with our team. We looked at what change we were going to test, when and how we were going to do it, and who would we involve. How long was our cycle 1 going to be? So our do phase involved collecting our baseline data and documentation. So we completed this cycle and collected our data over 2 weeks in January, 2 weeks. And then we also completed our staff questionnaire and recorded the numbers of staff we had trained on site. When we had all our data gathered, we submitted it for review with Julie and Fiona, and we met virtually to discuss the outcome of our cycle 1. So one thing that we noted was the low numbers. At that time, we had a low number of stroke admissions. We decided that we would like to repeat it for a longer period in cycle 2. Some of the things that came up at the end of cycle 1 was the colour of our assessment tool. We were finding it difficult to pull it out from notes. It was another white page in the mix. So we changed it to a blue one, and also we noted that we needed to up our communication with the staff on the ward. So we repeated our PDSA cycle with number 2. We planned it again, we met with the team, we updated everybody on the results of cycle 1, and we proceeded with refresher education sessions on the stroke unit. So these were sessions we completed at safety pause in the morning and via messaging groups on the unit. For our due phase, this time we collected our data for 4 weeks. In our study phase, our change created a positive effect, and we increased the number of patients screened. At the end of cycle 2, we met to review, and we had achieved 100%. We decided to complete our QI project at the end of cycle 2. So here you can see our results. So we had achieved our 100%. So we went from 86% to 100% in cycle 1 and continued to achieve 100% in cycle 2. Although our aim wasn't to look at the 4-hourly KQI, we can see that as a result of our focus on the swallow screen, our 4-hourly KQI also increased. So the national percentage for 2021 was 43%. So we have surpassed that, but there is some work that we need to do around this in the future. So what did we learn? There was lots of learning opportunities, but there was also some challenges along the way. We've seen that from changing the colour of our swallow screen and tool, it allowed for easy identification within the medical and nursing notes, and this meant it was easy to transfer to the High portal for audit data collection. We made everybody more aware of the swallow screen and tool and the documentation and the communication. So we had clear and brief communication sessions with staff at safety pause, and we updated about the status of our QI project. The challenge with communication for staff was with our high numbers trained and with shift work, it was hard to catch everybody. So our biggest learning for us was it was think big and act small. We were overachieving maybe, but we made some small changes and we reached that target. There's always going to be room for improvement. Teamwork was really important, and we were lucky that our team on site worked very well. How will we maintain this level of achievement? So we're going to continue brief education sessions, some focus around the time of the release of the audit data from INAS, and we will celebrate the accomplishments with the staff on the board and present our findings at every opportunity we're given. I'd like to hand you over to Fiona. Thanks for listening.
Thanks, Margaret. Hello, everybody. My name is Fiona Connaughton, and I'm the National Clinical Programme Stroke Nurse Lead. And I'll be just covering a few takeaway tips and tricks in implementing QI. So I just have the one slide that I'll be covering, and then it will lead on to a few questions after this. So I suppose just to start, I feel it's all about preparation. So you fail to prepare and you prepare to fail. I can't overemphasize documentation. So document before, during, and after the implementation of your QI projects. Do not rely on memory. It can get you into some hot water. The more you read, the less you know. The more you read, the more you know. I would have found at times that the information that is out there is quite overwhelming. Sometimes it may lead you to not starting. So I would say just start. You have enough information. Use a framework. We use the model for improvement, and I think a framework can give you a great structure. It also can explain to you how the QI tools in the toolkit can be used and when they can be used. Leave assumptions at the door, and I know Margaret touched on assumptions earlier on, but we can assume at times how the QI project is going to go, what way our team is going to be, how people are going to act, but you can never predict. So leave your assumptions at the door. Your QI project will evolve along with you and your team. Know your toolkit. So know the tools within your toolkit. It is important to use your project charter, and we would have found it's a great tool for documentation, and it is a great resource to look back on to see what your actual project aim was. What was that SMART aim? It allows for what you're going to do and what you're not going to do. It prevents project creep. Also be aware of your stakeholder mapping, your process mapping, your PDSA cycles, your timelines, the Gantt charts. Joan, Julie and Margaret touched about measures data, but also don't get too caught up in how you present that data. We would have felt at times, oh, you had to use a run chart, but you don't. Use the chart to present your data that suits your team. Also, it's not all about the data, it's what you learn along the way. And Margaret nicely touched on this as well. It is what did you learn along the way? That is what will help to sustain your project. So what is your project idea? Remember, not all change is improvement, but all improvement is change. And that is a familiar quote to some. Keep it simple. And don't be afraid of your quick wins. Your quick wins will allow people to remain motivated when they're not that over familiar with QI. Margaret touched on, think big, act small. It's sometimes those small changes that can make that bigger improvement. Know your styles. So know your own styles and be able to adapt your style. Sometimes we like to use, for example, a bit of humor, say in process mapping. Sometimes it's not altogether appropriate. So you need to be able to adapt dependent on how your team are on a given day. Observe your team dynamics. Remember, if it's a team that's working in a hospital, they may come with a bit of history. So it's important to be able to facilitate those teams. So know yourself, know your team, and that blanket approach does not work for everyone. So sometimes an example is in communication. Sometimes people have that email fatigue. It's okay to lift the phone and ring a team or have your face-to-face meeting. Some teams may need that, others mightn't. Be very aware of psychological safety. Establish some ground rules at the get-go. Everybody in the room are coming with a set of skills and experiences. They mightn't all equal, however, everybody is there for the benefit of the patient. Remember, QI at times can favour the loudest voice. Also, the culture embedded in a system. Be aware of the culture that is there. Don't go out at the get-go to change the culture. It might happen further down the line, but be aware. Be honest about your own knowledge and experience. You don't have to be a QI expert to lead or to help facilitate a QI project. It's all about balance, so it's weighing up. Aim to support and encourage without taking over. So as a QI, if you like, facilitator, we are learners also. We have timelines, we have deadlines, but it isn't important not to be pushing and take over somebody's QI project. One activity at a time. If you go doing your process mapping, your PDSA cycles, all in the one meeting, you risk exhausting yourself and exhausting the people in the group. Be cognizant of people's time, their workload and stressors that they come into the meetings with. A lot of the time people are coming in from busy wards into your QI meetings, so be aware of that. And just to end, I think be brave, feel the fear and do it anyway. Take that first step and just start your QI projects. And that's all from me. Thank you.
A big thank you to all our presenters, Joan, Fiona, Julie and Margaret, for sharing the power of audit and your passion for improvement and what can be achieved. I'm handing you over to Dervla now, who's going to just look at what we have in the chat box and complete out our session. Thanks, Dervla.
Thanks so much, Maureen. And just pulling on what you're saying there, it was just absolutely wonderful to look at that journey from a national clinical audit, looking through to a national clinical programme and the work you were looking to undertake and how that was implemented on site through quality improvement, really seeing that integration of clinical audit and quality improvement. It was a wonderful journey to go on. I just want to cover a few of the questions that are in the chat box because I think they tie in very well into the into the presentation, both Julie and Margaret and Fiona as well. So one of the questions, and I think it ties in with yours, Julie, because you referenced that you were looking to standardise the swallow assessment tool. One of the questions is, what swallow assessment tool did you use in the 4 pilot sites? Was it the same tool?
Well, we didn't change the tools that pilot sites were using. So in this phase, every site that we selected used their existing swallow screening assessment tool. So I think they varied across sites. So in some sites, I think the Yale was used, in other sites, the MGHSST. So it was different in sites, and that wasn't a target for this phase of the project to change that tool. So I mentioned that we established an expert advisory group. So that is something that expert advisory group has been looking at over the past year. And we will look at that now in the next phase of maybe encouraging people to use one single tool. And we think that will really make a big difference on the ground in terms of resources and training staff and helping with that sustainability as well, I think, that you mentioned, Dermot.
And Margaret, which tool did you use on your site? Just people may be interested to know.
There's no name, it's just a tool that was developed on site.
Okay, perfect. Yeah. Thanks, Margaret. Julie and Fiona, one of the questions here is, how were the 4 pilot sites chosen?
Sure. Yeah, I can take that one if you want, Dervla. So really, it was quite simple. It was just we tried to get geographical. We didn't want it all to be in the Midlands or all in Dublin, so we tried to get it spread through the country of 4 different sites. And we also wanted to try and get a mix of smaller sites and larger sites. And I suppose we wanted also to have sites with, different experiences of swallow screening. So I think Joan mentioned at the beginning as well, how some sites were actually performing very well or above average already, and some maybe were struggling a little bit. So we wanted to kind of get a broad representation of how swallow screening is working nationally at the moment, and try and pick sites with different records.
And Julie, now it's not a question in the comment box, but I'm sure people will be interested in it based on that question, is about the plans beyond phase 1 and 2.
Sure.
Your plans around going out to the other, is it 20 sites?
Yeah, so I suppose the goal of this phase was really to look at that overall swallow screening rate and to learn from our pilot sites. So certainly we have learned a lot from our 4 pilot sites, and we hope to bring that into the next phase of our project, which will be next year in 2024. And at that stage, we want to take the learnings and go national. So go to all of the hospital sites and try and implement a quality improvement project there. And we'll also probably look at that other target around the timestamp as well. And also incorporating the plan to get a module up on HSE land for swallow screening, and just see the implications of that as well, in terms of reaching our targets and sustainability, etc. Yeah.
That's great, Julie. So I suppose we're saying to any other sites who are on the call that they can expect to hear from you.
Yes, expect a tap on the shoulder soon.
That's great. So there was a few questions in and around training. So it was firstly, what staff were trained? And then in relation to swallow screening, and then was there supervision or checking of the competency with this skill? Would I direct that towards Margaret or?
So here in Sligo, so we have 17 staff nurses on the stroke unit trained. The 2 clinical nurse managers on the ward are trained. I myself is trained, and my registered advanced nurse practitioner in stroke was trained. Our training came from the speech and language department here. We completed a competency document, and then there was an actual training, an oversight with supervision to complete the training, and then you got signed off. So it was all done in-house through the speech and language department.
Brilliant. Thanks, Margaret. And Margaret, just one final question that maybe I can direct to yourself. We just had a query about how did you approach screening patients who had a stroke while in hospital rather than being admitted with a stroke? Was that something you came across during this work?
Yeah, and we come across it frequently.
Yeah.
So, if there is an in-hospital stroke, we will be alerted through the bleep system. So on either my first point of contact or the AMP's first point of contact, when we see the patient, we will perform the screen there when we go to see them. So they could be on another ward, maybe a surgical ward. So we just do it on our first point of contact. We're generally the first person to see them, and it can be some time then before they kind of filter through to the stroke unit.
Okay, and we just have a question in now that I think ties in as well. It's and might be the second last question for the session is, when the patient is admitted at weekends and nights, is it more difficult to adhere to the guidelines?
Yeah, it can be, depending on, I suppose, what staff is working. You know, not all the staff nurses are trained. So if there isn't somebody on the shift, it will be the next available person, you know, to complete it. Not that it's difficult to adhere to it. I suppose that's where we miss out on our 4 hours. You know, it's more the 4 hours that's impacted as opposed to completing the swallow screen, because it will be done at some point. Like, I will probably have contact with them Monday morning, or my colleague. So we will complete it if it hasn't already been done, but it's the timestamp that's the problem over the weekend.
Just to say as well, Dermot, that's something that really the next phase we'll be looking at in next year. So it wasn't the direct target for this phase, but we're conscious that that's something for next year. Yeah.
Yeah, and yes, Julie, I was going to say that as well. We could see the 100% on the overall swallow screening rate, and we could see how the 4 hours had been affected positively by the work, but that wasn't the main focus. So just to conclude, just to the overall panel, I'm just interested in going back to that sustainability piece, and now that this has been put in place in the 4 pilot sites, and I suppose, Margaret, you can discuss specifically from your perspective about the sustainability of maintaining that 100% outside of a continuous quality improvement cycle. It's the bringing it in as business as usual. Have you been looking at that, Margaret? Do you see any challenges within that, really?
Yeah, you know, it's always going to be a challenge to try and sustain it. It was, you know, I suppose, a quick achievement, but we definitely felt from completing this project that communication with staff really helped. Regular communication, reminders. I suppose the joys of social media, there's a messaging group. You know, they look at the message quicker than they'll maybe come to your 5-minute presentation on the ward. So it's to keep reminding them, you know, reminding them about how well we've done. I suppose when the dashboard is released from INAS, you know, keep them up to date on that data that they might not have readily access to. It'll be hard work, but we'll stick with it and see how we go.
That's great, Margaret. And Julie, Fiona, Joan, I don't know if you have any last minute, even 20-second add-on to make before we conclude. No. So firstly, thank you, Joan. Thank you, Julie, Fiona, and Margaret. As I said, a wonderful presentation on a very important patient safety area, really. So I am actually just going to take about 30 seconds just to close out the session, and just to reiterate, as Maureen discussed earlier, about the different areas where you can follow us on social media across, similar to Maureen, I still can't say X, so I'm going to say Twitter as well, our YouTube channel and our LinkedIn. So finally, just thank you so much for your time and for joining us today. Thank you so much to our panel for giving us the time and giving us the insight into their work along integration of clinical audit and quality improvement in relation to stroke care. So that's the end there now. Thank you all so much.